Hey guys, it's Gianna, aka Midwifay. Welcome back. Today I wanted to talk to you all about the 4 P's of labor progress.
As always, I want to encourage you, please like this video, subscribe to the channel. It really helps me know which videos you guys like and what other content you want. So please go ahead and like and subscribe if you haven't already.
In the traditional medical model of obstetrics, we learn all about the 3 P's of labor. These are things that affect the onset and progress of a normal labor, so we're taught. These 3 P's include the passenger, that refers to the baby, the fetus, the passage, that refers to the pelvis, the mom's pelvis, and the powers, that refers to the contractions, the strength and frequency of the uterine contraction. A more updated view on the 3 P's adds a 4th P that actually midwifery really focuses on, and that's the psyche. That's referring to a mom's mindset up to and during her birth experience. I'm going to also add, this is not just mindset, this is environment, right? So we're going to go through these 4 P's in this video. So let's talk about our first P, the passenger. We've got our little babe here, okay? I always like to remind people that labor is the dance between 2 people, the mom and her baby, okay? So the passenger, this little baby, is our first P. Now, what are we talking about when we're talking about the passenger? So when we're thinking of the passenger, thinking of the baby, we're thinking of anything that can affect this baby's ability to go through the pelvis, okay? So we're definitely thinking of size. This is the #1 thing that is talked about, I want to say, in obstetric care. If you want to know about evidence on being induced for a big baby, please go to my Should I Be Induced My Baby's Big video. So we're talking about size of baby, big or small. We're talking about position of baby in the pelvis, okay? Definitely. Obviously, is baby breech? Which type of breech? Vertex, head down, and not just head down. We are talking about what way is the baby facing in the pelvis. Is the baby in a transverse lie, an occiput anterior or occiput posterior? All of these play a factor in labor onset and more specifically labor progress. Another thing we're looking at when we're looking at the first P of the passenger is any conditions that may be affecting this fetus, any fetal conditions. So sometimes because the mom and the baby are a dyad, right, there are conditions that the mom may have, maybe high blood pressure, that can affect blood flow to the placenta, and that can affect how the baby's going to tolerate labor. Or a diagnosis for the baby, such as fetal growth restriction. Again, that's implying that there's probably some kind of underlying pathology in the placenta, and it might affect how the baby tolerates labor. So when we say the first P is the passenger, we're looking at a lot of dynamics that have to involve this baby and how he or she is going to tolerate, fit, etc. in this labor picture. With all that being said, I want to reiterate the fact that the baby's position is the most important of all of these different factors that affect her first P. The baby's position to go through the pelvis is going to be the most important factor affecting baby, the first P. All right, let's go to the second P, the pelvis. Now, this is one that I think is really underutilized, understudied, undertaught in the medical model of obstetrics, okay? This pelvis is dynamic. You guys, our bodies were created, evolved, whatever your belief system is, to birth babies. So for us to develop this mindset that, oh, something's wrong, my pelvis is too small, it doesn't work, that doesn't make sense. Nature is smarter than we are, okay? So our pelvis is dynamic. All of these bones and ligaments are designed to work together to stretch, twist, open, and make room for a baby coming through. So please, if you don't hear anything else I say today, know that your pelvis is dynamic. We can work with it to get this baby into a good position. Another part of the passage is going to include the pelvic floor, okay? And that is a sling of muscle systems that lies right here that also we can work with. We can learn how to relax, how to optimize stretching in order to have more space and where we want it and not have space where we don't want it, to encourage the baby to come down in that optimal fetal position. When looking at the female pelvis, really the human pelvis, but specifically we're focused on the female pelvis, we need to know three things. There's something called the inlet. The inlet is how you enter in to the pelvis, okay? Then there's the mid pelvis, that's this portion here, okay? And then the outlet, this is this part, right? This is coming out, okay? So it is important to know when you're looking at labor progress, where is the baby in this process? Are we trying to get the baby into the inlet, okay? If we are, this is probably early labor, end of pregnancy. We're not quite there yet. When we're in active labor, we're working with the mid pelvis. What positions, what things do we need to do to open the mid pelvis? And then when we're looking at pushing and getting into that second stage of labor, we are looking at the outlet. What do we need to do to optimize to get the baby out? So it's super important to know the physiology of the pelvis and what area are we working with when we're talking about the passage, when thinking about the second P of labor progress. Again, unfortunately, in traditional medical model of obstetrics, this is not something that is really well taught. In fact, just the other night at work, one of the third-year residents of a 4-year residency program asked me to explain to her what different positions should be used when a baby is stuck in labor, right? It's not something traditionally that they are taught. In midwifery school, we're taught it a little bit more. But again, I will say in the traditional medical model, hospital-based, it's something we don't put enough emphasis on. And I wish that I had done spinning babies earlier, done a physio birth class, all these things that I've now done and spent time pouring my time into. I wish that it was a required part of my training. I could have been able to serve many women and families much better than I did at the time. So the anatomy of the pelvis is super important when understanding that second P. Unfortunately, in 1930s, 1933 or so, there was a classification of female pelvis types. This is called the Caldwell-Malloy, I'm assuming named after men who discovered it. And it goes over what were thought to be the 4 common female pelvis types: gynecoid, android, platypeloid, and anthropoid. So this was what was thought of as the 4 types of pelvises that women have. These pelvis types have since been debunked by several sources. There was inherent racism in it, saying that Black and Latino women had different, more incidences of that anthropoid pelvic type or platypeloid pelvic type. Now, if you're looking at those pelvises in that picture, right, in order for a baby to pass through, you're not going to want that narrow inlet or this round oblong inlet, right? And that's what these pelvis types are alluding to, an inherent defect in this woman's body. So again, there has been a lot of data that has debunked these pelvis types, and we now know that more importantly than pelvis type, if there is one that is pathologic, more important is the relationship between the fetal position and movement in labor to move through the passageway, that second P. The last myth I want to debunk with the second P is this idea of a narrow pelvis. I've heard this from many women who have had long labors or perhaps have ended in a cesarean, and that they were told by their provider, yeah, your pelvis is just too narrow to pass a baby through. And I just want to stress that that is very, very unlikely in the US and in many developed countries. To truly have a pathologically narrow pelvis or a pelvis where your bones are too strict and not able to move would have to do with a significant vitamin deficiency or calcium deficiency, which we really don't see in the US and in developed countries. So if you were told by your previous OB or by your current OB that your pelvis is too narrow, I really challenge that assumption, and I want to point you in the direction of evidence that says that that's really not likely to be the case. All right, now we're going to move on to the third P, okay? And that is contractions. Now, I don't have a fake uterus for you, so what I will do is I'm going to just pull out my other 2 Ps and emulate the powers of a contraction, right? So baby is coming down into the pelvis. Let's say we're in the mid pelvis here, which is often where so many of labors get obstructed, okay? We need contractions. This is what your body creates on its own through the release of a hormone called oxytocin. When you're being induced or your labor is being augmented in the hospital setting, far too many times we use pitocin, which is the synthetic form of that, okay? So your body is going to cause your uterus to have contractions, which is going to squeeze the muscle, bring the baby down, squeeze the muscle, bring the baby down, squeeze the muscle, bring the baby down, and that in turn is going to dilate your cervix, which is invisible and I don't have down here. So this third P, the powers, is involving many things. How strong are the contractions? How frequent are they? How long do they last when they're happening, right? If you're having just a whole bunch of kind of short amplitude, short intensity, like doom, 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 that might not be making as much of movement as long, intense 1 minute contraction break. That's every 3 to 4 minutes, right? So we really want to see that contractions are intense. That means their strength is strong enough to dilate that cervix, that they are long, they're really lasting ideally a minute or so, a little bit longer, and that they're every 3 to 4 minutes. Now, does physiologic labor, a normal spontaneous labor, always fit that picture? Absolutely not, right? Whatever dilates your cervix is clearly effective contractions. Clearly we've got effective powers at work there if you're dilating and your labor is progressing. One thing I want us to consider and look at that, again, the traditional medical model does not look at as often at all, looking at P number 1, the fetus. What is going on? If we've got strong and regular contractions with Pitocin, because you've been on Pitocin and we're cranking it up so that we can give you strong and regular contractions. If we're doing strong and regular contractions, but you're not dilating or the baby's not coming lower, why? I want us to consider that first P, the fetus. Maybe the baby is in a malposition, okay? This is something called asynclitism, where the baby's kind of coming in sideways. This is a common cause of obstruction in labor, in mid-pelvis. You can see, looking at this, no matter how strong our contractions are, if I'm forcing, frequent forcing, but this baby is coming at an angle that is not optimized for that pelvis. Doesn't matter how strong, how many contractions we give, it's just going to kind of get baby stuck even more in that position. And so that reminds us of P1 and P2, the importance of movement and really intentional movement throughout labor to work with those first 2 Ps. All right, we've gone over the first 3 traditional Ps, the passenger, the passage, the powers, and now let's go to the psyche. This is the one that, again, I really feel like midwifery hones in on. I'm looking at you as a whole person, as a whole woman approaching your birth. Where are you right now in planning for this birth? What is your mindset? What environment are you setting up? This is what working with a doula, a childbirth educator, a pregnancy coach like myself, this is the part that we can work on the most, is the psyche component. I like to remind my patients and my clients that although we are highly evolved as humans in 2023, we are still mammals giving birth, and that means we need to feel safe, quiet, and undisturbed. Like any animal giving birth in the wild, we need to feel those things in order to truly be able to let the physiology of the process prevail. What I've learned through my years of experience in the hospital setting and now as a pregnancy coach is that in order for a lot of modern women to feel that first piece safe, you need to be prepared. You need to know what is normal, know what to expect, know your hospital's policies and procedures, know what questions to ask, how to ask questions, how to establish this relationship throughout your pregnancy prior to the birth, okay? So much of feeling safe is feeling prepared, heard, and empowered. So that's super important, okay? The quiet and undisturbed piece, that's all gonna look different for everyone. Focusing more on preparing yourself throughout your pregnancy journey and what does it mean for you to feel safe, quiet, and undisturbed during your pregnancy and during your birth experience. That's what I want to help you hone in on as a pregnancy coach. All right, so those are the 4 Ps of labor progress. The biggest takeaways I want you to get from that is that one, the baby's position is more important than any other things that affect that first P to the baby as the passenger. I want you to know that your pelvis is dynamic. That passageway was designed to move, mold, switch, shift, shape to get the baby out. And three, when you've got powers, when you've got strong, regular, forceful contractions and dilation is not happening or baby's not moving down, let's consider going back to those first two P's. What do we need to do to optimize the baby's position in the pelvis? All right, that's all I've got for today. I hope to see you next time. Bye-bye.